Hello everyone, presenting you this case of grade 4 endometriosis with huge endometrioma with deep infiltrating endometriosis for total laparoscopic hysterectomy with bilateral salpingo oophorectomy. So both the ovaries are adherent to posterior surface of uterus and uterosacral ligament complex, and right-sided we have huge endometrioma. So we always start with good sigmoid mobilization. As we all know, sigmoid is a gateway to retroperitoneum, and once we mobilize sigmoid nicely, we get access to ureter, which is a very vital structure we have to visualize first before starting surgery for endometriosis. Here we can see a lot of endometriotic deposits in the peritoneum itself. Here we have identified round ligament. So assistant is holding round ligament at the junction of medial 2/3 and lateral 1/3. So we cut open round ligament, and as this case is planned for total laparoscopic hysterectomy, so we are opening retroperitoneum by oncological approach. So we can notice here left-sided retroperitoneal area is quite free. The peritoneum is not involved here, so we can proceed in stepwise manner by dissecting this area layer by layer, of course. So you can see beautiful spaces over here. Everything is going layer by layer. Don't fight with the tissues. Don't push the tissues till the breakage point. So we have to provide as much as sharp dissection here to avoid undue bleeding, because once bleeding is there, our field gets obscured and the vital structure what we want to see get obscured. So here we are going millimeter by millimeter. So the benefit of using ultrasonic scalpel over here is it helps in clipping up these small vessels and provide bloodless field, and it helps in millimeter by millimeter dissection. So at this point, we have identified uterine artery at the origin, and we are clipping this uterine artery. So clipping of uterine artery helps in as much as devascularization of uterus. So here the main principle is once we have identified ureter at the brim, we have to follow ureter and keep proceeding laterally. So after clipping of uterine artery, we dissect parallel to ureter. We create a window between infundibulopelvic pelvic ligament and ureter, and we proceed for left-sided salpingo oophorectomy. So once this annexa has been divided, we have one lesser structure to worry about in the pelvis. And we can have one extra hand in the pelvis to help us. So till now we are proceeding in stepwise manner: sigmoid mobilization, ureterolysis, uterine artery coagulation at the origin, division of infundibulopelvic pelvic ligament, and removal of left-sided annexa. So we follow ureter till it enters tunnel so that we can lateralize ureter completely away from our field of vision. So this whole peritoneum is involved around ureter and infundibulopelvic pelvic ligaments. So once we send this tissue for histopathology, either we get endometriosis or we get sideroblast in the tissue, which confirms that there was blood at some point of time in this tissue, which again confirms the presence of endometriosis. After peritonectomy, we proceed for pararectal space dissection. So we follow this fact. So uterosacral ligament is on lateral side and rectum is on medial side. So the fat is guide and friend at this point of time. Keep following it till we reach the uterine torus or till the insertion of uterosacral ligament. So we have opened left-sided parietal space. Now we have ruptured huge endometrioma so that we get some space in the pelvis to work. So once the content of cyst has been evacuated, we can mark important landmarks in the pelvis again. So you can see a lot of endometriotic deposits over the peritoneum. Again, we proceed for retroperitoneal dissection on right side. So we mobilize ureter on the right side. So here in this case, as you can see, the left-sided retroperitoneum was little bit free, but the right-sided is more involved. It's bit difficult to mobilize planes here as planes are little stick to each other. So by gentle strokes of harmonic scalpel, we keep on dissecting. And at some point of time, once we stop getting planes by blunt dissection, we have to resort to sharp dissection. So here you can see obliterate umbilical artery in the front, and now we are taking uterine artery again at the origin to devascularize uterus as much as possible here. So you can notice that tissues are all stuck here. So more of involved area on the right side. Now after we have coagulated uterine artery at the origin, now again we follow ureter and try to lateralize ureter as much as possible as we have to divide uterosacral ligament here. Now we again follow the concept of creating window between infundibulopelvic ligament and ureter, and we divide infundibulopelvic ligament. So after division of ligament, now we are lateralizing bowel. Here again we are trying to enter right-sided pararectal space. So the benefit of opening pararectal space is we know exactly the place of bowel. So the area effectively between ureter and the bowel is now nothing but affected due to sacral ligament, which can be easily taken and divided so that we remove all the affected peritoneum and uterosacral ligament at this point. So the hypogastric nerve is usually 2 centimeter below the ureter. So at this point we know exactly we have not gone deep and the nerve has been preserved. So the hypogastric nerve goes and merges with pelvis splanchnic nerve S2, S3 and S4, and which helps in bowel, bladder and sexual functions. So even if at all both-sided parametrium is involved and we have to perform deeper dissections, we try to retain one-sided of parametrium. We don't compromise both side of parametrium to avoid unnecessary bowel, bladder and sexual function impairment. So once we know the exact position of ureter as we have dissected ureter till tunnel, so now we can divide right-sided corner structures safely, keeping ureter under vision. So you can observe minimal blood loss as we have already taken bilateral uterine arteries at the origin. So you can see a lot of peritoneal endometriotic deposit over here. So we will remove all the deposits. Get a good grip on this annexa. We have already freed it from all the sides. So it's attached only from above. So it's quite easy to divide it. So after this annexectomy, we'll get plenty of space in the pelvis and we will dissect bowel from the center. So as we have dissected both sided parietal space, now only central rectal dissection is remaining, which will be performed with the help of bipolar and scissor. So we perform coagulation with the help of small burst of bipolar at minimum current, and we divide tissue with cold scissors. So at this point we need good bipolar and good pair of scissors over here. So we need to proceed absolutely millimeter by millimeter here, and you can see endometriotic fluid coming out. So a good ball preparation is must, and we should always give good traction on the bowel while we cut with the help of bipolar and scissors. As you can see, even there is endometriosis in parietal area, so sharp scissors are required to divide this endometriotic implants. Of course, a good and clean field and a good imaging system is always required to perform such complex cases. Keep a constant eye in the direction of rectum, where exactly rectum is going. So once in doubt, we can take help of rectal probe to delineate rectum, where exactly rectum is going. So as we advance in endometriosis cases, we learn to identify different type of tissues and orientation of rectum, because many a time there is also lies a cyst in the rectovaginal area, which will make our surgery further difficult. So once we have mobilized rectum adequately, now we know we can divide this tissue, which is not significant over here. So this is importance of mobilizing rectum from both sides. It will help in further dissection of rectum from central area. So at this point, we now know that rectum is attached to the torus of uterus only with the help of some fine bands, which we can easily divide under vision. So you can notice there's cyst in the vagina, which many times makes our surgery little difficult and to dissect the space. So you can notice that we have mobilized rectum adequately to perform hysterectomy. So the next step is mobilization of bladder. So always have a habit of lifting bladder nicely. Lift this UV fold at the junction of 0.5 centimeter from attachment to the uterus. Don't go very close to the uterus, otherwise you'll end up having bleeding. So once we lift a full bladder, we get an area of demarcation from where we can always mobilize bladder. Sometimes bladder can play tricks with you. It can be folded upon itself. So learn to identify different types of tissues so that we remain in proper plane and we could dissect them easily. So we have coagulated uterine artery. Now we are dividing by left-sided Macken-Rod ligament, as we have already dissected and we have divided left-sided uterosacral ligament. Here we open the vault without need of putting vaginal tube over here. So we remain flush to the cervix to avoid unnecessary loss of length of vagina. So you can notice one thing, we have achieved normal supple looking tissues over here after performing much of peritonectomy and excision of involved uterosacral and whole of peritoneum. So this should always be the motto of performing endometriosis surgery. We have to excise every involved peritoneum and every involved tissue to provide the patient complete relief and to avoid future recurrences of endometriosis. So once we have performed colpotomy, we can decide to mobilize bladder a little bit more. And now we have completed the hysterectomy part. We are closing the vault over here with the help of polyglactin suture. So at this point, you can notice that we have achieved complete macroscopic excision of all involved endometriotic implants. So this should always be the motto of surgery. So thank you so much for watching the video patiently.